Feel free to. Yeah, thank you.
Okay, thank you all for coming. And I am May Wang. I'm an affiliate of CCPR. I'm from the School of Public Health. And today we're really pleased to welcome Professor Nathaniel Osgood from the University of Saskatchewan. Nate has been working with our research group for quite a few years. And he is very well known for his work in agent-based modeling. That's kind of how we met a few years ago. But I want to start with a little story because the first time Nate came to do a boot camp here that was supported by CCPR, we experienced that major flood from the first water mains, if anybody remember. And now he's here with the fires. Anyway, he's very much very valued member of our research team. So let me formally introduce him. Nate obtained all his undergraduate and graduate degrees from MIT in electrical engineering and computer science. And he is truly an extraordinarily interdisciplinary thinker and scientist, as you're going to discover in the next hour. He is not only a professor of computer science at the University of Saskatchewan, but he's also affiliated with the Department of Community Health and Epidemiology and Bioengineering Division. And I remember clearly the first time I actually heard Nate speak, and he doesn't remember, I'm sure, it was at an NIH conference. And it was on system science and agent-based modeling. There were probably 8 or 9 people, all the speakers in the room. There were only 2 people in the room whom I understood, and one of them was Nate. Anyway, needless to say, he's very well known for his work in agent-based modeling. He's very much in demand. He conducts amazing boot camps here in the U.S., in Canada, in Australia. I'm not sure where else, Nate. When he was here at doing this first boot camp, that whole session was supported by CCPR, the local Los Angeles County Department of Public Health, thanks to Tony Crow, and also with some funding from our NIH grant. And I also want to say that he's not, I've mentioned he can cross disciplines very easily, and as a result, he not only does a lot of great academic research, but he also consults with the Ministry of Health. So in very recent years, Nate's interest in understanding human health has led him to develop some really cutting-edge mobile technologies, and he's going to be giving another talk tomorrow that's going to be in the School of Public Health on smartphones and wearables in public health, and that's going to be at 12 noon if anybody would like to attend that. And so today he's going to be talking about his work, the work that he's so well known for in dynamic modeling for health in the age of big data. So please help me welcome Nate.
Thanks so much, May, for the too kind introduction. It's a real pleasure and honor to be with you here this afternoon and to share with you some of the very exciting work that we've been privileged to be part of in this confluence of, on the one hand, data science, system science, and computational science. I often give variants of this talk with the subtitle Beyond Myth and Madness, giving a nod to the comment of epidemiologist Phil Zuckerman, as passed to me by a colleague, Mark Orr, who once noted that theory without data is myth, and data without theory is madness. And today I'm going to be giving a glimpse of why I'm so excited about the prospects of bringing together dynamic modeling on the one hand with what's commonly called big data on the other, to really allow us to ground our theory with detailed information regarding many factors that have traditionally been elusive for us to quantify, to measure, and to allow us to more quickly spot inconsistencies and spot gaps in our theorizing in a way that can allow us to develop more and more confidence in our understanding of the world. So within today's talk, I have a special challenge compared to many that I give, because I'm going to try to make sure that everyone in the room come from diverse backgrounds. On the one hand, has some understanding about what I'm talking about, where I'm coming from when it comes to this notion of dynamic models. There's many misunderstandings about those models. There's often confusions about what they involve, reflecting the fact they go by many names. They're used for many different purposes. And I'm going to try to touch on that. I'm also going to try to touch on characteristics of big data, a term that I feel is overhyped, often misused, and it's used in highly inconsistent fashions amongst the different stakeholders with which I circulate internationally. And I'm going to be anchoring this talk with a couple of vignettes, as time allows, that I'll be discussing concrete ways in which we're bringing together these elements of big data with elements of dynamic modeling to yield health insight. And these are just a small set of a wide variety of these types of work that we have going on with stakeholders from various ministries of health in Australia and multiple provinces in Canada, but also with partners here in the US. And I'm going to try to particularly emphasize with each, not so much all the details about the projects, that would be prohibitive, but this interface between data on the one hand and dynamic model. How did the two come together? In what ways do they mesh? And as we'll see, there's quite a number of different ways in which dynamic modeling substantively can take advantage of, and indeed in turn inform our understanding of big data and what data we even need to collect. I'll then try to leave you with some conclusions following what will no doubt for many of you be kind of a buzzing, blooming confusion of new concepts and ideas. So the motivation for this work that brings me here, and indeed wakes me up each morning, is our need, the urgency to confront ever more complex health policy challenges which our world faces. We're dealing in today's era with a growing number of entangling of different health conditions. Up in Canada, TB and diabetes, maybe chickenpox and shingles. It may be aspects of mental health on the one hand and HIV/AIDS. We're dealing with distressing mental health gaps that seem to grow yawning by the year. A graying of the population that besets a lot of the developed world, and it forces us to deal with very complex patients whose needs are often not met and are compounded by social isolation, despair, in ways that confound strictly health issues and get into profound social issues. We're dealing with life course impacts of early life insults in critical periods and even in utero exposure. And increasingly, we're dealing with health disparities that clog our conscience and that force us to deal with this entangling of health issues and inequalities and social injustices. And increasingly, we are working to combat, though sometimes at a position of institutional disadvantage, very adversarial corporate actors, whether it's tobacco companies or big pharma or food companies that have their agendas and that our public health system seeks to respond to, often in ways that are delayed and incomplete. Now, this was quite a laundry list here, and they're united by the fact that not only do they constitute some of the most pressing health needs out there, but they share a feature that was sometimes called, in a technical sense, complexity. Situations where we're grappling with systems where the behavior of the whole in its response to our interventions cannot be reasoned about purely in terms of a reductive exercise in understanding the parts. Just as We know that you could be the best mechanic in the world, know all about everything there is to know about car engines and drivetrains and axles and all those sort of things, but know very little about why traffic jams form and how to prevent them. We're dealing here with issues, emergent issues that are coming out of complex systems where in order to grapple with the challenges we see, we need to go beyond an understanding of each piece of the system and put them together in a way that gives respect to the intertangling and reasons about the high-level policy resistance, the behaviors we see at a high level that transcend any one piece or an average of those pieces. And these systems have been well studied for decades within other spheres. In engineering and physical sciences, we've known about dynamically complex systems for decades, and we know that in a very technical sense, the behavior of the whole is very different than the sum of the parts. If we have a system like this and we formulate an intervention portfolio consisting of several interventions, the impacts of that intervention portfolio are profoundly different than simply the sum of the gains from each intervention in isolation. Sometimes those interventions amplify each other. They're synergistic. Sometimes they work at cross purposes. Sometimes they cancel each other out. Within these systems, they react often surprisingly and pervasively to interventions. We may intervene on one piece of the system, seeking, for example, to change individuals' physical activity levels through altering the physical environment. We may find that it ripples through to aspects of mental health. We may find that it ripples through to aspects of eating behavior and ripples through to changes in the social milieu. And as a result, we find ourselves facing the fact that siloed attempts to address these challenges run into real issues. Often in these systems, for technical reasons, there's a real distal impact, a set of pronounced delays between cause and its effect. It's often unclear what the effects are. Think the life course impacts of early childhood traumatic exposure. Think about the work of Barker from the decaying industrial cities of the Midland in England, and looking at the effects from the earliest childhood experiences on later life chronic disease. We're dealing with effects that are delayed, they're often distal, that are often multifaceted. They manifest in many areas of life and life course, and that are reciprocal. We have mental health issues affecting risk of weight gain, and weight gain affecting mental health issues. And you get these feedbacks involving many of these systems. And these systems are nonlinear in a technical sense, which amongst them means the effects of the intervention portfolio are very different than the sum of the effects of each. But it also has to do with tipping points, where if we can just make enough of a difference, we may see a qualitative change. A small additional investment makes a qualitative change in the results. We also know with these systems, going back to the work of Heathcote in York in the 80s, looking at gonorrhea, for example, that the tail can wag the dog. It's not about dealing with, in some sense, just the largest population subgroups and expecting to make the difference. Sometimes it's the disadvantaged groups, the most vulnerable groups, small they may be, that make the defining difference for addressing the problem most fundamentally. Think about core networks for STIs, for example. There are effects of scale that confound implementation science. And the system responds to our attempts to change it in ways that can lead to policy resistance, whereby our interventions are diluted or defeated by the system's response to them. And we know that in these systems, lock-in effects can be pronounced, and heading off an issue of addiction early on can eliminate the need to make much larger investments to deal with the effects and pick up the pieces after the fact. We're so often dealing with these trade-offs where, an early intervention judiciously chosen can really cut down on the resource needs down the road. Now, there's many areas where these factors obtain. Some of the biggest challenges they pose is to ask what's going on. To what degree does the evidence involved support my hypothesis? Where's the situation likely to go next? What's driving these current trends? Sometimes, as in rising cases of reported cases of communicable disease, it may not be even obvious if rising cases are a good sign. We're identifying them quicker, where our surveillance is more effective, or a bad sign. There's rising incidence. A second issue that these challenges really confront is the need to intervene. Where do I best intervene? How do I intervene? How soon shall I see effects? How to scale up? Questions that have to do with implementation sciences and their unique challenges. How to make the implementation financially sustainable. Now, system science has provided us, in its varied forms, a toolbox of techniques to help us deal with these systems where the whole is greater than the sum of the parts. I like to call it the science of the whole, because just as you need not just specialists to work on renovating your home, people who specialize in the electrical or the plumbing or aspects of the heating and ventilation systems, you need a generalist to put them together. So it is with these systems. We need the people who can not only reason about the angle of the road, the particular vehicles on it and their speeds and driver reactions, but can put them together to an understanding of the traffic jam as a whole, as a phenomenon. And system science can help us reason about these complex systems and has an admirably large toolbox for doing so, which we've tapped many tools from. But one of the most profound of those tools is what is commonly called dynamic models. And these models, in some sense, represent how things might work out there to serve as learning tools and help us share our assumptions with others. So without going to this in great detail, these models provide a way to capture in an operational form, a form that's quite precise, sort of our working hypothesis about the way things operate in the world, the way the underlying processes interact in the world. And if built and used wisely, they can help us learn faster by testing the consistency of this understanding, of this hypothesis, with empirical evidence. They can help us examine the impact of system-wide changes in one or more areas of the system, and they can help us understand system vulnerabilities, ways we can change the system structure, and identify improved ways as working together. These models are sometimes misconceptualized as crystal balls, things that you plug in assumptions to. They're black boxes that give you results. And I think a much more accurate way to view them is thinking prostheses. They're thinking tools. They help us think more consistently through the implications of our assumptions and help us spot inconsistencies, latent cases where our assumptions just don't add up. They don't jibe with the evidence that we find available from the empirical world. Because, and this gets into the thinking prosthesis side, when we break our foot, when we pull a hamstring, we may use crutches to get around because it complements our limitations and allows us to achieve full functionality despite those limitations. So it is with models. Our limitations here, though, are cognitive. They have to do with reasoning consistently, rigorously, and precisely about how our assumptions translate into outcomes, and to be able to inspect to what degree that's consistent with evidence. And models provide us a way of doing that complement our limitations. They use computer simulation to ask what are the logical implications of these assumptions in terms of what they imply, and let us test if that's consistent with the evidence. So there's many uses of these sorts of models. Amongst them are sharing our assumptions, making them explicit, taking them out of our heads, putting them into the light of day and sharing them with others and allowing others to critique them. They help us spot inconsistencies between our thinking and the evidence that's available, and to serve as what-if tools to identify policies that are more likely to be robust or effective, and to then test those models with those consistencies, always recognizing that they are going to be incomplete and may need refinement. Now, a major barrier, and this gets to the next section of my talk, a major barrier to building these models effectively, to building them to greatest use, is the fact that often evidence concerning the factors, the behaviors, the exposures we want to capture in the model is lacking at the level of detail we'd like to use to inform the model. We have limited data about location, where people spend their time. Our studies have demonstrated huge gaps between where people report spending time and where they actually spend time for important segments of the population. This has implications for understanding exposure to environmental risks, to access to care and to resources, barriers to physical activity. We know since the NHANES 3 study that people's self-reporting of physical activity is often at striking odds with what's reported by accelerometry or by physical measures of maintaining that. Trying to get information about spatial proximity of individuals, who they've spent time around, we've also found big gaps in the studies where we've very carefully studied the contrast between self-report and what's recorded. Social context, aspects of their decision-making, rules, etc. These are areas where it's hard to collect data in a way that's not terribly burdensome or terribly inaccurate in other cases. And yet the challenges in seeking to build models that richly characterize behavior related to these complex challenges, absent an understanding of these behaviors and exposures, often the ability to quantitatively evaluate trade-offs between policies is really limited. I'd particularly highlight here a need that comes up for a lot of our partners. We work very closely with ministries of health in several provinces. Also had privilege to have some advice giving for the Australian federal government, as well as a Ministry of Health, as well as the ACT, the Australian Capital Territories there. And a lot of what our partners in those areas are interested in is the effects of intervention. So when we put in place an intervention that may be fairly broad in its impact, say moving low-income individuals from low-income neighborhoods to mixed-income neighborhoods, we're interested, say, at change in obesity levels. They're interested in understanding, why do we see these effects that we do? And the challenge that confronts us for many of these, whether it's the Moving to Opportunity program here in the States or similar programs in Canada or Australia, or indeed elsewhere in the world, is the fact that there's many pathways to effect. There's many generative mechanisms that might explain changes in obesity levels. Some might work through the greater degree of perceived safety in the mixed income environment, and therefore the encouragement to moderate, vigorous physical activity outdoors. Maybe it's aspects of the walkability, moving from crumbling sidewalks to a situation where there's good infrastructure or good recreational space available. And their impacts in sedentary behavior and physical activity. Others have hypothesized the changes in obesity levels amongst teenage girls, for example, seen in Moving to Opportunity, may have been significantly mediated by availability of healthy foods, so changing to a new food environment and the healthiness of the diet. Others have pointed to the time they spend at home with the social networks cut from the old neighborhood or lessened. These girls may be spending more time at home, eating more, cooking at home rather than outside, be exposed to healthier food environments at home, and that may contribute to lower obesity levels as well as lowers of pro-criminal involvement seen. All of these are reasonable hypotheses, but often it is hard to understand what's going on in these intermediate pathways to really best explain these outcomes of obesity levels. And to really understand many of these, we go back to the barriers we encounter in measurement. So my thesis here is that the advent of big data in its varied forms will fundamentally synergize and help enable dynamic modeling for health policy by allowing us to fill in many of these gaps involving these areas where things are prohibitively burdensome or lack accuracy of self-report, and in terms of filling in our understanding of which causal pathways are most active in driving the results that we see. So I'd like to substantiate that thesis here with an understanding of what I mean by big data, a term, as I said, that I feel is much hyped, much abused, and used very inconsistently in different contexts. So within this area of big data, you'll find people slapping the term on a wide variety of electronic data sources, from social media feeds to the types of data we get from building or environmental sensors. Our buildings are increasingly robots that record, on the order of seconds, humidity, temperature, pressure information. There's point of sale records that many studies are tapping into. There's data from sequence data on gene activation, for example, that many researchers used, as well as data from browsing behavior in consumer electronic devices, such as I'll be speaking about greatly tomorrow. But rather than listing these as various exemplars or examples, I'd like to use what I find the most useful operational definition of big data. And this actually does come from, perhaps appropriately enough, Google. And it's characterized by the 4 V's. Big data is characterized by volume, that's the big in big data, by velocity, meaning that it's high temporal sampling rate. It gives us data at a much higher level of temporal resolution than traditional data sources. Rather than having phone calls once a month to ask for self-report on physical activity or sedentary behavior over the past month, we might be getting many sample points a day, or through accelerometry, perhaps thousands of sample points a minute. It's high variety, meaning a given source of data, perhaps it's data on people's Facebook status updates, perhaps it's data from smartphones, maybe giving many types of information. So on the smartphone right now, it's giving accelerometry, gyroscope data, my location is measured by GPS and Wi-Fi triangulation, and it's giving information for many smartphones on pressure, temperature, whether the screen state is on, etc. Finally, there's an issue of veracity. This last one is often misunderstood. It's not to say that each data point gathered is necessarily incredibly accurate, but collectively, the data that's collected via these elements of big data often gives a very compelling understanding of certain aspects of what's going on, where you are. Could be aspects of who you're with, could be aspects of your physical activity context. And collectively, these measures often less subject than self-report to incompleteness and to confabulation. And the data is often much more temporally proximate to certain health events of interest, certain exposures or symptoms, etc. So I'd like to give a flavor of some of these data sources. We're dealing in the big data area for health with a wide variety of types of data that are available. On the one hand, I'll be talking about search monitoring, gathering aggregated data on a daily basis about search volumes from certain regions that may be taking place with respect to certain search queries, all the way through to mobile data collection via wearables and smartphones. And generally, the further right you go here, it's finer insights, greater recruitment challenges, more flexible, and greater concerns about privacy. So to give you a sense of types of these data, consider search volumes worldwide. There's somewhere over 60,000 searches per second which take place. This is aggregate data. It's regional in its delineation of geography as given out by the companies involved, whether it's Microsoft or Google. we have quite a degree of temporal resolution afforded by that day and geographical data. This is looking at a whole set of different search queries related to flu from Quebec during the period of the flu pandemic in 2009, 2010. It is daily data, and it's as reported by Google Trends. And what you'll see is that the different queries give somewhat different readings of what's going on, but the overall trend is unmistakable in terms of searches for flu. And you could do similar look at similar data, say, for whooping cough. This from Australia. You'll notice almost a phase change here, a regime change, where over a long period of time it was sort of going along at similar levels for several years. And then there's something happened here where it was changed in a big way, the amount of searching related to whooping cough. And I'll tell you that this was a highly publicized case of baby Riley, a case of a baby that died because of exposure to pertussis, to whooping cough. Passed away. It caught the media's attention in a big way, and it seems to have altered in a persistent way that lasts several years awareness of pertussis and the need for pertussis vaccination. These are searches for naloxone, a key element of the response to opioid overdoses within the Canadian context, and you could see the sort of geographic distributions here. Now, this is aggregate data. It's not related to particular individuals. If we get closer to the individual, we're talking social media data. Social media data provides a glimpse of diversity and expressed attitudes across population, gives a sense of variation in platform use. And each platform is very different. Twitter is a publishing platform where it's a public forum for expressions. Facebook has private channels and needs to be approached very differently for ethics reasons. And blogs such as on Tumblr are quite different yet in terms of their prospects for harvesting them and their volumes. To give you a sense of Twitter, for example, here we're dealing with somewhere over 300 million users. US has about 60 to 70 million active Twitter users, those who post reasonably frequently. And roughly speaking, you're talking about 8,000 tweets a second these days and greater than 10,000 during bursty periods, such as the US election this past year. Geotagging and geoinferencing is possible on many tweets. We do a lot of that, and you can filter by different aspects of geography, time, etc. Now, the platform I'll be talking about tomorrow is a platform for smartphones on Android and iOS on iPhone. Here we have an app that can be used for with consenting individuals to opt into studies which collect diverse sensor and ecological momentary assessment and crowdsourced information, and which can elicit really rich information on location, physical activity, spatial proximity, social context, and communication. It can also elicit very rich information that are derived on exposures, exposure levels to different environment, and because of the variety here, we can cross-link this information to get sort of combined pictures, for example, where physical activity is being undertaken over geography, or to understand where social contexts are taking place, or where contexts of a veteran with PTSD, actually how long they're spending time with their service dog nearby. A foremost goal for all of this work is security and confidentiality, and whether it's the option to snooze, to opt out of the data collection, or use of encryption, or other aspects to censor the type of information that's available. Privacy and security are foremost needs and goals, and are expected, rightly so, by ethics boards. Okay, so we've seen dynamic models, we've seen big data. How do these two come together? Well, it turns out that they come together in a number of different ways. There's no one story about how they're combined, but there's a couple ways that are recurrently revisited by many particular examples. One thing is that they allow us to be combined to take empirical evidence that's gathered via these data sources and use it to inform policy modeling. So we have these models that need parameter estimates or that need to be calibrated to data involving people's activity, people's exposures. And we can often take data directly from our larger scale data sources, and we can translate it into the model. We can place it in there directly. And some of the work that we've done with a wide variety of partners, whether it's with the Lung Association or American Legacy Foundation, now Truth Initiative, and Dana-Farber Cancer Institute, or whether it's aspects of the Good Food Junction, a community-owned grocery store, really leverages this. And I'd like to talk about one example of this at Foodborne Illness. So we have some work that's been followed with quite some interest by Public Health Agency of Canada. That's sort of the analog in Canada of CDC here in the States. We have been constructing models looking at foodborne illness and its spread in communities for a number of years. But those models highlighted a number of key uncertainties involving interpretation of the data and data gaps that prevented them from reaching their full potential. As a colleague who's specialized in the area of food chain safety for many, many years told me, she characterized foodborne illness. She said the foodborne illness cases that we know about are not merely the tip of the iceberg. They're the spike of ice at the very tip of the iceberg. You know, it's something like estimated to be less than 1% of all cases we know about of foodborne illness, despite their high impact on absenteeism, high impact on people's quality of life, and fairly frequent occurrence. And our modeling identified a number of issues, from risk perception to issues of accuracy of recall, the occurrence of subclinical illnesses that don't drive people in to seek care, and vendor food seeking that were important limiters to what we could gain from the models in terms of policy insight. So to address this, we did turn to, and this was in conjunction with partners in our School of Veterinary Science, School of Public Health, and also in Public Health Agency of Canada. We turned to smartphone-based data collection using the system I showed earlier. We used the system to allow individuals to record when they were feeling ill and report things about their symptoms. When they were eating, and to report aspects of what they were eating. And our system, our web-based system for study administrators, allows us to go back and kind of look at the reports that various participants have made in terms of what they were eating, their descriptions of the food, and their characterization of their symptoms and in context for cases where they encountered them. To give you a sense of the longitudinal nature, the kind of high resolution nature, what I show here is three trajectories. For ethics reasons, I've had to slightly alter a bit of this data, and I've also masked out the times associated with it. Because of the individual trajectories shown here. And what you'll notice is the individuals are reporting over time when they were eating. Here in green is when they were eating at home. The yellow is when they were reporting eating elsewhere. And the red was when they were reporting feeling ill from plausible cases of foodborne illness. Was something we looked at as qualifying symptomology. And you can see these three individuals are distinct in their patterns, both in terms of the burden of foodborne illness and in terms of the timing, et cetera. But you could see fairly dense recording associated with their eating habits. And for each, we were asking them to report via photos of what they were eating. We also used ecological momentary assessments to query recently what did they eat and what was the nature of that food. Did they take leftovers home? Now, the amazing thing from my perspective, having worked in primary data collection for some years, is the degree of involvement which we had in this study. And it's not unique to this study. For example, if you look at, this is a histogram showing through successive bins here, the number of participants that fell into one bin or another. And this is actually about half our study. We ran it in two separate groups and two separate contiguous time periods. And this is the first half. And what you could see is that a very large fraction of the participants, the majority in fact, reported 85% or over cases of where questions were asked of them. They answered those questions on the device. Individuals reported where they were eating food, and because it's all GPS stamped, we know where those occurred over the course of our city from which the participants were recruited. We also could record aspects of their symptomology, and by linking the two, we could ask, where was non-homemade food eaten at a location before credible cases of plausible foodborne illness within the 24 hours before that. And we could look at hotspots associated with this, hotspots based on where they were spending time on the one hand versus where they actually were reporting unusually large numbers of cases of foodborne illness. And bring these two together allows us to complement what's already in the model with additional components. We actually examined, I didn't have time to go into it here, but accuracy of recall. We looked at what they actually reported physically versus their recollection of it a certain number of days later. We captured aspects of subclinical illness, could look at what fraction of those cases did they actually seek care, their food seeking at particular vendors, and we could record as well aspects of their risk perception and risk awareness over time. Now, all of this information can go into a model, and we have models that sort of characterized over time, and I thought I had a nice picture of it, but I guess not, sort of aspects of their health state and its evolution over time. So, where they're exposed to illness, whether they develop subclinical or clinical illness, and look at times for recovery. We could try to understand each of those using, for example, the fraction of cases that are subclinical versus clinical, or how quickly they recover and start going to engaging at food seeking at vendors. Those are all aspects that we can collect from the data from the phones and use to put in as assumptions of the model. Another thing that we investigated with this model was actually the use of similar tools for intervention. So we asked, okay, what would the gain be if we had a tool like this? If we could gather information from a small sentinel group in the population, say 1% of the population or 2% or 4% of the population, that would carry around an app like this and would report cases of subclinical illness. They report the basic symptomology, and they report something about where they're eaten over time. To what degree could we use that information to meaningfully reduce the burden of foodborne illness in the population by responding more quickly? Because any one individual may not be aware of others who have fallen prey to illness at the same restaurant, but collectively maybe they'd start to put a red flag around a particular vendor, for example, or a particular time period, a particular type of food. So we looked at this, and we found fundamentally that even a small fraction of the population, say just 2 or 4% of the population, carrying an app like this and reporting cases of illness where it's followed them around. Maybe the data is kept in escrow until a possible outbreak is occurring, and then it's released to the public health authorities to allow them to tap it. We found that we could greatly reduce the occurrence of foodborne illness by allowing us to stop incipient foodborne illness outbreaks in their in their tracks by reducing the spread of foodborne illness by about 60%. So here we were using a similar design as an intervention. We used a simulation model to evaluate what would the gain be from an intervention like this in terms of slowing down the spread of illness, in terms of allowing us to zero in on locations compared with traditional techniques. I'd like to talk about another case which has to do with suicide prevention and in cases of adverse mental health. I don't have as complete a vignette to give for this, but I'll simply mention that we have work going on with some of our northern communities which have been hard hit by mental health and addictions burden, as well as by one of Canada's only school shootings within the past decade, looking at using mobile technologies with a different interface, but the same underlying system to follow individuals who over time report adverse ideation, and to be able to recognize incipient cases of depression based on changes in sedentary behavior, mobility patterns, and aspects of socialization. We further have coupled that with a set of mechanisms designed by psychiatrist partners that help provide them with tools to try to work with difficult feelings and to try to encourage them towards healthy ways of raising their mood and ways of quickly connecting with others within their social network. Within this context, we're leveraging a number of models that we've built with partners within Canada, Public Health Agency of Canada, and the ministries within our province, together with partners in Australia through the Sachs Institute, to try to take this sort of data and use it in a more comprehensive suicide prevention initiative. As another component, I'd like to talk some about tobacco and nicotine product use and choice. This is work that we've undertaken both with partners at Harvard and Dana-Farber on the one hand, at NIH, intramural researcher Kelvin Choi, and Erica Pence at our home institution. And here we were interested in looking at use of e-cigarettes and its impact on tobacco use and its impact on overall use of nicotine and risk of nicotine addiction. So the dynamic modeling which we undertake was undertaken by a senior student of mine, Kurt Kruger, as well as a second student, Young Chin, for Public Health Agency of Canada. And here we were looking at characterizing choice behaviors that an individual might choose e-cigarettes compared to cigarettes, compared to quitting over time, and its relationship to availability of these products and nicotine levels within these products. So within this context, we had models that were depicting state of using nicotine products, using purchasing behavior and procurement and location between different areas. And we used mobile technologies in these areas in that form of that same smartphone-based Ethica system to examine the micro-behavior of product use. And our goal here was really to inform in the same way this model and its parameters with data on micro-behavior. So we could actually capture what was being shown within the model and calibrate it to the actual patterns of behavior we see. But in the process of so doing, we actually had a very different insight regarding the use of these products, and particularly e-cigarettes, that changed how we were going to model them. So the goal here was to mesh modeling with this sort of data collection as a parameterization tool. It ended up actually changing our theorizing about what needed to be in the model. And I'll come to that. So this was a glimpse of the study interface. Same system, just different skin on it. Here are the buttons by which people could report smoking or vaping, etc. There were button-prompted surveys that would ask them what prompted them to use a cigarette, what their aspects of their social context. But we also asked questions prompted to them using these micro-questionnaires, these ecological momentary assessments that we pop up to check completeness of their results. And we had, again, very good response rates, here upwards of 70% in terms of the fraction that were answered. And fascinatingly, although we recruited individuals who are dual users of both, we found people overwhelmingly were reporting occurrence of vaping, recurrent use of e-cigarettes rather than cigarettes. Smoking was represented in a significant number of samples, but individuals were much more likely to have reported vaping in the past hour than smoking. And this gives an example of some of the data. So here we have, for given individuals in red, vaping behavior, and in sort of bluish color here, smoking. Here we notice that different individuals had different balances of these two. But one thing that really stands out from this graph at casual observation is the fact that vaping seems more continuous, prolonged, in some cases almost seemingly pathologically so, given that this stretches across rounds of several days. And it's more concentrated. Looking further into the data with findings that I don't have time to share here, what we found quite strikingly was that there was a profound difference in how e-cigarettes and cigarettes were being used. We should have known this in glimpse. In retrospect, it's one of those glimpses of the blindingly obvious. We should have known it from the start, but we never thought to question it. The assumption here that we had in our modeling and that we had in our mental models on which those models were built was that people were using e-cigarettes on an episodic basis, much like they were using cigarettes. They'd go and have a break for e-cigarettes and come back and resume their activities, just like they would for cigarettes. It turns out that this was a reasonable but terribly flawed assumption. It turns out to be far from the case. And several aspects of the data pointed us to what some of the individuals, when consulted directly, told us matter-of-factly, which is that for a lot of these individuals, e-cigarette use is not an episodic sort of thing. It's not something where they go, use it for 2 or 3 minutes, they're done with it, just like they would burn down to the base of a cigarette and be done. With an e-cigarette, there's no physical limit like there is with a cigarette in how long you can use it, other than the cartridge exhaustion, which can take hours, days of use. So these individuals were using e-cigarettes for hours and hours on a continual basis. They just, every 30 seconds or minute, they take a puff of the e-cigarette, keep it around, and just use it for very, very long stretches. So the whole notion that our model had in it of sort of a defined discrete time for smoking and discrete time for e-cigarette use, as much as we wanted to parameterize that model, we found ourselves thrown back in terms of questioning our basic assumptions as captured in that model and having to reconceptualize what that model needed to look like to anticipate adequately the impact of policy change. We also had extensive data from this on the nicotine levels that people were using, the e-cigarette product type, their procurement behavior, where they obtained it, which pointed us in helpful directions in terms of some of the policy impacts. So, ladies and gentlemen, I'd like to submit to you that within these areas, we have a natural confluence of the type of information that's gathered via these big data mechanisms, sensors being one of the many types of data, and dynamic models. The sensor data grounds the models. It can ground in very high velocity observations. It can really help help spot model inconsistencies with the data, and it can help, in other cases, parameterize the model, provide very specific information needed to build the model in a reliable way. We can calibrate the model in some cases to patterns that we see that can't be reduced to any one parameter, but which the model needs to stay true to. And we can use it to, we can use this sort of data to stimulate hypotheses for what's going on in the world that are more grounded. Dynamic models can help us take this data that we're gathering through big data and help us capture the regularities that underlie it, and it can help us identify aspects of the underlying behaviors which may not be collected and sort of fill the gaps between what we are collecting, to have a more general theory about what's going on here. We can further use the dynamic model, it turns out, to generate synthetic data to test strategies for analyzing that data. I'm going to mention one other case here, and we'll finish up, of how we brought together these techniques. Here, we're bringing together a model that, this is a published model contributed by Ross Hammond and Josh Epstein. Josh was for a long time with Hopkins as a leading scholar on complex systems, and has since moved to NYU, I believe. Ross is a close colleague of mine at Brookings. And they had a model of contagion of fear and disease, where they posited basically in cases of outbreaks, there's two phenomena taking place that involve contagion. One is contagion with respect to spread of infection. Another is contagion, so that's pathogen-based. Another is contagion with respect to concern or they called it fear, anxiety about it. And we took a look using a technique we've used very successfully. It's called particle filtering. It's a sequential Monte Carlo method. It's a technique for taking together a model on the one hand, empirical data over time on the other, and combining them to yield a model that on an ongoing basis is regrounded in available data. It's regrounded in the latest evidence in a way that often illuminates latent areas of the model that you can't directly measure. It does so using these machine learning techniques that are rigorously defined and that have been used extensively in other areas, particularly robotics. And fundamentally, it takes a model and data coming in from the world and builds a consensus estimate from them, and at the same time informs a sense of distributions over different areas of the model. How many people are likely to be susceptible now within this model? How many people, for example, have likely recovered at this point from infection, even though they may not have sought care? How many individuals are in a state of anxiety with respect to this illness? So we had data from public health agencies within Canada concerning cases of validated illness based on reported cases, hospital admissions, intensive care unit admissions, etc. We also had data from internet searches for two different regions, for Manitoba and for Quebec, is the two regions we looked at. This data was more noisy. On the hierarchy of evidence, it ranks far below lab-confirmed cases. But we did something rather interesting. We used this particle filter to bring together lines of evidence. At first, we only did it with the model and the higher quality evidence, the evidence from lab-confirmed cases that actually sought care. And bring these two together with data up to a certain point, we found that the model was more accurate than an unassisted model. It had learned from this data to this point. It had a pretty good understanding of what was happening now. But looking forward, it quickly became uncertain. Looking more than a week ahead, it quickly became uncertain. How would this outbreak evolve over time? What's likely to come about in another 10 days, 2 weeks, 3 weeks? So whether we were looking, for example, at data from clinical illness or data from lab results, it just wasn't enough to fully ground the model to give very strong projections further out. By contrast, when we combined this model with two lines of evidence, the higher quality evidence and the Google search data, we found we could look forward with much greater confidence. We could look forward and predict with much higher confidence in this sort of high posterior density region the likely continued occurrence of the outbreak, the continued trajectory of the outbreak. We found that this transcended this particular region. We were able to do the same thing and found the same basic findings with multiple jurisdictions, whereby the model combined with just the higher quality evidence fell short, combined with both sources of evidence, search data, search volume data on the one hand, and data from clinical cases, it was much more accurate. So here we're taking advantage of big data in a different way. We're taking a model, we're keeping the model informed on the latest evidence as it arrives, in a way that the model incorporates that evidence, it learns from that evidence, and then we can use it to look forward to anticipate where things are likely to go. And we can estimate latent states of the system, states where we can't measure them directly. Undiagnosed individuals who are out there, for example, or individuals who are in anxiety out there but haven't presented to the care system. And we can use that sort of model, having learned from the empirical data, to ask questions about intervention strategies. So I'd like to make a few closing remarks. We're dealing with a very exciting time with respect to availability of new data sources. These data sources don't fit neatly into the classic hierarchy of evidence as canonicalized by practitioners, and they require novel methods to make use of them, but they're collectively very powerful. The types of electronically captured data that we're talking about here is very wide and broad in its capturing of behaviors and exposures. Many aspects of commodity devices, such as Fitbits that many people in the room have with them, or smartphones that most people in this room are carrying, can really serve dual uses as versatile platforms for ecological momentary assessments, sensors, and for crowdsourcing information from individuals, whether it's quantitative information about their physical activity or sedentary behavior over time, or self-reports about perceptions, barriers and supports they see in their community for physical activity, etc. Empirically grounded models of the sort we're talking about here to yield best effect for quantifying trade-offs between policies really do best if they're grounded by data on human behaviors, aspects of exposures that are very burdensome to collect normally. Coupled with models, big data can allow complementary insights with those models, and particularly can be used to sharpen dynamic modeling in terms of its findings about the system and its accuracy of the assumptions within it. By using the machine learning techniques, such as sequential Monte Carlo methods, which we saw in the last example, we can really enhance the power of dynamic modeling. This is not a small thing. Having our models be able to automatically learn over time as new data becomes available really changes the game in many ways for how we build those models and how we use them. And a key use of this data for social and health policy is to help us learn more quickly and more effectively from interventions. Because when it comes to designing intervention strategies to take advantage of a model like this, we are best suited to make use of reasoning about how things are likely to take place across multiple pathways. These models often depict multiple changes in behavior and outcomes across multiple pathways. And that's the same type of information that can be gathered by many of these types of big data. We can gather information about store use for that move from a low-income neighborhood to a medium-income neighborhood To what degree are people taking advantage of the grocery stores that offer fresh fruits and vegetables? To what degree are they making use of the ball courts and recreational spaces? To what degree are they out and about on the sidewalks? To what degree, using EMAs, are their perceptions of safety really enhanced in a way that leads to higher levels of physical activity? How much time are they really spending at home versus eating out? These are all the type of questions we can probe with big data as well, especially using mobile technologies. You combine them with a model that's more inclusive and includes many of those factors, and now we're talking about the prospect of learning from interventions in a much more effective way. Whether or not an intervention is successful or not, it can be a great opportunity to learn why it was not successful, which pathways were changed successfully, which pathways may have worked at cross purposes, weren't changed at all, or changed in adverse directions. In short, we can learn from an intervention failure to become a success of learning to design much more effective interventions when combined with models that can help us ask what-if questions about counterfactual interventions. So, in short, I do believe that we're dealing with a new era for dynamic modeling, an era that is increasingly going to see dynamic models leveraged to their greatest ability and to inform policy discourse in a way that's ever more grounded. So I'd like to provide my sincere thanks to those who helped me to make it possible for me to come here. Mei Wang's group, close collaborators on a number of projects that are really cutting edge and that speak to much of this work, and to CCPR for providing the office space and a great environment for me to meet individuals interested in this work, and everyone who made possible this talk and my visit to UCLA. So thanks very much.
Thank you so much, Nate. That was a lot of information, and I'm sure many people have questions, so I think we have a little bit of time.